her health dialogue tonight on women's health. So I'm Dr. Rob McMaster. I'm the Vice President of Research for Vancouver Coastal Health and also Senior Executive Associate Dean for Faculty of Medicine for Research. This is a really important area. I'm really pleased to see the turnout and really the variety of speakers that we have tonight. So research really is to find a solution to really focusing on how do you move research into practice. And I think this is a really good example in the talks you'll hear today, is really seeing how the value of research, how it can apply to many different areas, and particularly to women's health. So with UBC, the Faculty of Medicine, really also pleased, and this is in collaboration with the Women's Health Research Institute at Women's Hospital that we all work with, is that UBC has given formal center status to the Women's Health Research Institute. So it is now a recognized center from the Faculty of Medicine. And I think that shows the importance of this area of research across the field, where VCHRI, Women's Health Research Institute, really differs from many of our other institutes, which are somewhat geographically bound, whether it's at a hospital site or a given area. Women's health really covers the province, to Canada, and global. And it's, I think, an exciting area to see how the impact coming from Vancouver really is spreading out really across the world, whether it's from Africa or whether it's from Asia or whether it's from North America. So we're really pleased to really welcome back Pamela Ferriman to be the host tonight. And we were just chatting that we had Pamela, we were at an event, I think when I first started this position at VCH on a public lecture. We actually can't remember what it was on. But this is our first women's health one, so it couldn't have been that. It was probably cardiology. But really pleased to have Pamela, who I think is a well-known medical health issues reporter for many years. Stories appearing in print, online, Vancouver Sun, Vancouver Province, other post-media newspapers across Canada, and also her blog, Medicine Matters, I think is followed hopefully by everybody in the room, really to drive that message home of, the health issues, what are the important health issues, and having a dialogue on that, much as what we want tonight, as a dialogue. She has been awarded numerous Journal Art Awards, fellowships, and many multiple awards from the New York Times Foundation and the Canadian Institutes of Health Research that funds much of the research you'll hear about tonight. So please join me in welcoming Pamela as host tonight. Thank you.
Good evening. Welcome. So I'm going to be your moderator this evening, and as you've heard, I've been covering BC-focused health issues for over 20 years. I cover clinical medicine, research, science, and health policy. And I was keen to take part in this symposium because, first of all, you have a stellar lineup of experts, and they're talking about personal health issues, which, although quite common, rarely get enough attention. I'm sure we're all going to learn plenty this evening from the experts that we're very fortunate to hear from tonight. So thank you for making the effort to be here. Before we begin, I just have a few reminders for everybody. Please turn off your phones. The washrooms are located just outside the theater near the main entrance. And there is an evaluation form. I think it's going to be just outside the door at the end of the event. Please complete it before you leave the building. Our speakers are going to be presenting their talks until 7:15. After that time, there's going to be a question and answer session, which is always, I think, the most fun part of the event. And if you could write down your questions, that would be great so that you don't forget them. And we'll have some mics in the theater, and we'll come to you when you stick your hand up. We are live tweeting this event, so you can join the conversation or get the highlights at VCH Research or by searching for the hashtag HerHealth2018. My Twitter handle, just since we're talking about Twitter, is Medicine Matters, and I hope that you all consider following me. As you know, the theme is women's silent health issues, and tonight you're going to learn about some of the key research findings in this area and some of the current treatments from these very well-known and respected clinicians in all of these areas. So it's my pleasure now to introduce our speakers for this evening. Dr. Marette Lee will discuss her work in HPV-related diseases. Dr. Paul Young will speak about pelvic pain and endometriosis. Dr. Lori Brotto will present her work on sexual health. And lastly, we're going to hear from Lana Berry, who's going to share her personal journey and discuss her experiences as a research participant. Also joining us tonight over there is Tia Young, and she is a graphic recorder with Drawing Change. This is a new fascinating dimension being added to this evening's events. She's going to provide a graphic reflection of the evening's key messages. Everyone is encouraged to check out the recording up close and take photos, so please be sure to stop by. I'm now pleased to introduce our first speaker for the evening, Dr. Marette Lee. Dr. Lee is a gynecological oncologist at the VCHRI Hospital and BC Cancer. She's the provincial colposcopy lead for the cervical cancer screening program at BC Cancer. She's involved in guideline and program development for cervical cancer screening and colposcopy in BC. She's also a clinical assistant professor in the Department of Obstetrics and Gynecology at UBC. Her research activities relate mainly to the lower genital tract and to HPV. Please join me in welcoming Dr. Marette Lee.
Good evening, everyone. I'd like to thank VCHRI for inviting me to speak this evening. This is a unique opportunity for me. I'm usually talking to other doctors and such, so VCHRI and the WHRI have both been a great support to me in the past and continue to do so. So, gynecologic oncology, for those of you who don't know, is a bit of a mouthful and often a conversation stopper depending on the context. But what it means is that I do surgery for gynecologic cancers, so cervix, vagina, vulva, etc. So that means that a significant proportion of the women that I treat have cancers that are caused by HPV. Now, although many healthcare workers and a lot of the public are more aware of HPV and what it means to us, there are a lot of gaps and there are a lot of misinformation out there. So whether or not you have been knowingly affected by HPV or not, my hope this evening is that through this dialogue, we'll generate awareness about HPV. And through that, I hope that you will be empowered through that knowledge that you gain, that you will cultivate compassion for those who are affected, that you'll be motivated to eradicate the stigma and create an environment of openness about HPV, as well as other women's silent health issues that we're here to talk about this evening. And finally, I want to give you some hope, because I'm going to talk about what we can do to prevent and reduce health issues related to HPV. To that end, my key messages this evening are as follows. So first of all, HPV infection is very common, but most people never know they've had it. People with symptoms or health-related issues or with knowledge of HPV infection experience significant emotional and mental distress in addition to the physical symptoms they may have. Knowing more about HPV, however, can alleviate some of the stress and anxiety and can help people cope with the disease and its effects. And finally, the good news is that now many HPV-related diseases are in fact preventable. So I'm going to start with a few basics. There are 40 types of HPV that affect the human anogenital tract. So that's not really a common term. What that means is cervix, vagina, vulva, perianal area, and anal area. And then also the oropharynx. So that's in the mouth and throat. And that, of course, males and females both have a mouth and a throat. And in males, the anogenital tract obviously includes penis and anus. So as a rule, HPV infections go unnoticed. Your immune system deals with it, Most infections are cleared within 18 months, and you would be none the wiser, and you may or may not have passed it on to one or more people during that time. However, some types of HPV can cause genital warts. These can be very distressing because they don't look very nice and sometimes they're uncomfortable. HPV types 6 and 11 cause 90% of genital warts. These are different from the 15 types that cause cancers and precancers, okay? Cancers and precancers happen when HPV persists for years and doesn't go away. And HPV type 16 and 18 are responsible for 70% of cervical cancers. And as for other body sites, HPV 16 again is the major culprit and causes the majority of cancers there as well. So I'm going to step out of the facts realm for a bit, and I'm just going to share, give some idea what women might experience when they have HPV infection or HPV-related disease. And these are quotes from papers and authors who've studied women who've been affected by HPV. It just made me feel so dirty. There's a sort of shame. There's a leper type of feel. And another woman said, angry, very emotional, extremely. I couldn't believe I was going through it, that I had something. You hear anything that has to do with STD, you're like, oh my God. I think the worst thing for me was just being so betrayed the way I was. Even so, I'm giving him all the blame, or I should be blaming myself, because I should have been more knowing or finding out, basically. I should have been protecting myself more so, and I didn't. So you get a sense of a lot of the shame and the self-blame and the guilt that comes from women who've experienced HPV. These themes come out over and over in various studies that have been done. Even knowledge of infection without any actual visible or symptomatic disease causes significant distress, even with non-cancer causing types. Although I believe it's starting to decrease, I still think there's a lot of stigma out there attached to HPV. Many women and many couples have difficulty coping with any type of HPV diagnosis. Depression, anger, and anxiety can persist for months and months. Relationships can be stressed, especially if people don't understand HPV and are not equipped to talk openly about something like that in the relationship. On the other hand, I've seen many people learn more about HPV and become empowered to speak openly with their partners and also open up dialogues with their friends and family. So I've been inspired by witnessing the power of knowledge and the hope that comes from sharing experiences. For most of us who've had HPV, there are no long-term health consequences. But for a few, there will be health issues. Some of these are temporary, some of these are long-term, or they may have long-term effects. I'd like to share with you a few stories to give you an idea of the physical health effects that women with HPV-related diseases experience. For example, a 65-year-old woman who's had multiple recurrences of vulvar precancer over 25 years. She keeps coming back for her checkups. Every couple of years, somebody finds something new, does a biopsy, finds another precancer. She needs to have another laser treatment or another surgery. Decades of issues. A 22-year-old woman with a history of organ transplant. Extensive vulvar and perianal warts that are extremely disfiguring and uncomfortable. Vulvar precancer mixed in with that, cervical precancer all at once, because she's on immunosuppressive drugs and her immune system is not able to handle the HPV that in most people would have gotten rid of. And finally, a 28-year-old woman who's had 4 procedures on her cervix for recurrent precancer of the cervix. On the 4th procedure, we find a cancer. She has to have a hysterectomy at the age of 28 years old. As you can see, the effects of HPV and its treatments on the body can be disfiguring. They can increase the risk to future pregnancies, or they can even take away the option for future pregnancy. A woman's body image and sexuality are affected, sometimes permanently, and everyone copes with this differently. Fortunately, most of us will never experience the situations described. However, whether we like it or not, we've likely had exposure to HPV. And one of my main goals tonight is to normalize HPV for you, for anyone. HPV is a sexually transmitted disease, but it's more common than not. It's kind of like a common cold for the sexually active. And I use the term sexually active here very broadly because HPV is transmitted between the skin and or mucosal surfaces. A mucosal surface includes things like the inside of the mouth or the vagina or the anus. Penetrative intercourse is not required to pass HPV. The most common HPV-associated cancer is cervix in women, and oropharyngeal cancer in men is the second most common. As you can see, cervix cancer makes up 35%, and if you add oropharyngeal cancer in women and men, it's also 35% of HPV-related cancers. There are other kinds of oropharyngeal cancer, which affect different parts of the mouth. That's sort of the more front areas of the mouth and the tongue. HPV-related ones are in the back and the soft palate. So the ones in the oral cavity cancers are alcohol and tobacco-related. About 25 to 35% of oropharyngeal cancers are HPV-related. So for women, cervical cancer was the first cancer discovered to be related to HPV, but as I've shown you, there are many other body sites that are affected. And people who've had disease at one body site are at more risk of having disease at another body site. Almost 100% of cervical cancers are caused by HPV. HPV infection is very common. Cervical cancer is not. Cervical cancer you can think of as a rare complication of HPV infection. Globally, cervix cancer is a huge burden. So we're very fortunate in Canada to have cervix screening, and it has reduced the incidence or the number of cervix cancers and death from cervix cancers by over 70% since its institution in the mid-1900s. Although cervical HPV is the most well-known, you can see that there's many other body sites affected. HPV hides in the surface cells on all these body sites, doesn't usually go into the bloodstream, so our body's immune response is sometimes not enough to protect us from a future infection of even the same type. So it's different from a lot of other types of infections. Although some new HPV infections tend to decline with age, in one study, even in women over 45, the new infections occurred in 12% of women over 5 years, and that number is higher with younger ages. And condoms are not as effective because they may not cover the areas either affected by HPV or vulnerable to HPV. So I know this is a women's health talk. I did read the poster. But HPV is shared between partners of any gender, so the nature of HPV infection in men might be relevant. The immune response of men to HPV is even less robust than that of women, so they can get infected with the same HPV type over and over and over again. And although the chance of getting HPV goes down with with age in general for women, for men, their rate of HPV infection stays about the same through their whole life. So, I do have some good news. We have a few minutes left, so I'm going to leave you with some good news. Based on vaccine studies, when the HPV vaccine is given to girls or women prior to HPV exposure, it prevents well over 95% of precancers related to the vaccine HPV types. Vaccination's like a seatbelt. You wear it because you never know when you're going to need it, and it could make a big difference. If we could guess who and when would need a seatbelt, we wouldn't bother wearing one maybe, except for those times, because they're kind of a pain sometimes. Maybe they're uncomfortable, they get in the way, they prevent you from reaching in the back and handing your kids something or putting your shoes away or whatever you're doing. HPV is the same. Getting vaccinated may protect you, and it's one action you can take to protect yourself going forward. Ideally, we give vaccines to someone who's never been exposed. They work the best in that situation. So that's what we need to focus on. But given the multiple HPV types out there, even if in those who have been previously exposed, there is potential for benefit. Many extended health plans now cover HPV vaccination. HPV vaccine has been extensively studied, extensively scrutinized. There have been hundreds of millions of doses given worldwide, and it's been studied by many independent organizations in terms of investigating side effects, and it has been found to be very safe. Since the introduction of HPV vaccine in many jurisdictions around the world, including Canada, and despite suboptimal vaccine uptake, so not great rates of vaccination, we've already seen decreases in genital warts and precancers of the cervix in real-world populations, including British Columbia. Because HPV takes years to cause precancers and even longer to cause cancers, it'll take a while to show effects on cancers. But now that we know HPV affects so many other body sites, even though the vaccine was originally designed to prevent cervical disease, it has potential to prevent a lot of other disease. HPV vaccines are about cancer and precancer prevention. In addition, there are many studies showing the vaccine can also benefit women who've had HPV-related diseases by decreasing the chance that it will come back. So there are 3 vaccines that have been approved for use in Canada. The 2V HPV, or the bivalent vaccine, covers the HPV 16 and 18, 70% of cervix cancer causing types. There's a 4-valent, covers 16 and 18 plus 6 and 11, which are the 2 main wart causing types. This 4-valent has been largely replaced by the 9-valent, which covers 5 additional cancer causing types. So 90% of cervix cancer causing types, and then the 2 main wart causing types. And these vaccines have been recommended for use in females 9 to 45 years of age are the study populations, and now the National Advisory Committee on Immunization in Canada has recommended that you can go outside that age limit for women, and then for males, the 4-valent and 9-valent for age 9 to 26. Again, you can go outside that age limit, and it specifically referenced populations who've already been exposed or had HPV-related issues, and giving vaccine to them. In BC, we've had a vaccine program since 2008, which started out just in girls. Thankfully, we are now including boys as of September 2017. And anyone who was born in 94 or later can actually get a catch-up vaccination through the public health system, can have it covered for free. You just have to reach out to a community health. Unfortunately, our vaccine uptake isn't that great. It's only 65%, so we've got a lot of work to do there. What else can you do? People with a cervix, the most important thing you can do beyond vaccination is to have cervix screening. So in BC, that means a pap smear every 3 years from age 25 to age 69. Make sure you get the results from your doctor. Sometimes they get lost and you need to close the loop. Symptoms of cervical cancer include bleeding after sex or bleeding between periods. Usually those don't mean cancer, but if you have them, you need to get checked out. If you have a lesion on your vulva, have someone look at it. It's embarrassing. A lot of people delay going to the doctor, don't go to the doctor. Sometimes doctors don't even look, either because patients don't want to or they're embarrassed, but make sure somebody looks. It's important. And finally, share what you've learned with your family and friends, and encourage them to take control of the aspects that they can and do what they can to prevent and decrease HPV-related diseases. Here's a few resources for you. These are all good websites because there is a lot of misinformation out there, so please be careful. HPVinfo.ca is put out by the Society of Obstetricians and Gynecologists of Canada, Immunize BC, BC Cancer, and the Canadian Cancer Society. And with that, I will say thank you and pass it on to my colleagues.
I told you we were going to learn a lot tonight. Thank you so much for that fascinating presentation. I have at least 4 story ideas from that. I had no idea that vaccination was recommended for women over 45 now. Next up, we have Dr. Paul Young. He's the Research Director of the BC Women's Centre for Pelvic Pain and Endometriosis and a staff gynecologist at the BC Women's Hospital and Health Centre, UBC Hospital, and VGH. Dr. Young is an assistant professor in the Department of Obstetrics and Gynecology at UBC. His research interests are on the pathophysiology of sexual pain in endometriosis, including psychological, anatomical, cellular, and genomic factors. Please join me in welcoming Dr. Young to the stage.
Thank you very much. I'll be speaking on bearing the unbearable, endometriosis and pelvic pain. So endometriosis affects 1 in 10 reproductive age women, or about 1 million women in Canada. So it's a very common condition. And it's defined as tissue from inside the uterus or the womb, which somehow grows outside of the uterus. So on the top left is a laparoscopic surgical photo of the uterus, and somehow this tissue is able to grow outside of the uterus and has the classic appearance of this dark pigmented tissue shown in the second photo. And if you surgically remove this tissue and look under the microscope, you'll see cells that resemble cells that come from the uterus. Endometriosis is associated with pelvic pain and infertility. And the pain symptoms range from painful menstrual cramps to more chronic pelvic pain to painful bowel movements to painful sexual activity. But it's very heterogeneous. So someone with endometriosis can have all those types of pain. Another person with endometriosis may have very minimal pain. And the same thing with fertility. Some women with endometriosis have totally normal fertility, and others have difficulty conceiving and require fertility treatment. Studies have also found an association with abnormal menstrual bleeding, a slightly increased risk of pregnancy complications such as early delivery, certain autoimmune conditions such as MS, heart disease, and a small increased risk of ovarian cancer. The treatment of endometriosis can involve several aspects. So one is hormonal therapy, and the rationale is that endometriosis is an estrogen-dependent condition. And so the hormonal therapy utilizes progesterone to antagonize the estrogen. The treatments include the birth control pill, which has progesterone and estrogen, as well as progesterone-only treatments. And this works really well for a lot of patients, but for a subset, they have side effects and they cannot tolerate it, or this hormonal therapy is contraceptive, so if someone's trying to get pregnant, it's not an option. Another treatment avenue is laparoscopic surgery. So that's surgery through small scopes, through small incisions, and that's how endometriosis is formally diagnosed and can be removed. So the photo here is showing some laparoscopic scissors which are cutting away endometriosis, which just has a whitish color in this particular patient. And good clinical trials show that surgery can partially improve pain and can also improve fertility. Thirdly, there's an increasing recognition of the importance of allied health care, so physiotherapy, psychology, and counseling, because there's more recognition of the role of the musculoskeletal system and the nervous system in endometriosis pain. While some patients do get pregnant after surgery for endometriosis, there is a subset who will require fertility treatment at a fertility center. So to demonstrate the impact of endometriosis on a patient, I'm going to go through a patient's journey. So this is Sheila. She's an amalgamation of different patients we've seen at our clinic. So we'll start when she's 16. So her periods have been painful since they first started. Now she's starting to miss school. She's missing sporting activities. So she may talk to her friends or perhaps a doctor, and she's told, well, period pain is just normal. However, moderate to severe menstrual cramps, especially that affecting quality of life and function, is strongly associated with endometriosis. Moreover, there's now evidence that a history of painful periods month after month, say starting at adolescence, is a risk factor for future issues such as chronic pain. Therefore, this is a symptom that's important to be acknowledged and validated and addressed. Well, Sheila's now 22. She's been taking anti-inflammatories such as ibuprofen, and she's been managing. But now she can no longer take these medications because she's developed an ulcer. And we see this not uncommonly in our clinic. So she stops the anti-inflammatories. Now she's having pain on most days. So even without having a period, she's having a pain almost every day, and also having pain with bowel movements. And she starts using a hot water bottle on her abdomen. And what this does is it can cause discoloration of the skin, and we call this the hot water bottle sign. So if we see a patient and we see this, we know she's having significant pain and using a hot water bottle for long duration or frequently. So she sees her doctor, she's prescribed hormone therapy, and she's better. There's improvement. She has some side effects. Often we see mood side effects, but she's able to tolerate it, and she continues on with her life. So Sheila's now 30, and she's been noticing that sex has become increasingly painful. And she again may talk to her friends or see her doctor, and she's told, well, you just need to relax. Or we have some patients where in the past a doctor told them, drink some alcohol and you'll be fine. Well, this is not particularly helpful, so sex is still painful and results in significant stress on the relationship. And similarly to menstrual cramps, painful intercourse is a symptom that's important, that's not uncommon, that needs to be addressed, and there's a variety of causes, of which endometriosis is one. And this can be treated, and this symptom can be improved. So Sheila's kind of living with this. She's now 32. Now the wrinkle, she's trying to conceive, so she has to stop the hormone therapy. So once she stops that, her pain goes up to 10 out of 10, and the stress just increases. Because in addition to the pain, now she's trying to conceive, and there's the month after month of disappointment when the period comes and the pregnancy tests are negative, and everything is just compounding. And so she goes to her family doctor and says, finally, I really need help. So thankfully, she is referred to a gynecologist, and she has the luck to see my boss and my practice partner, Dr. Catherine Allaire, who is a world expert on endometriosis. And the pelvic exam is done, and it's uncomfortable. So as I mentioned earlier, endometriosis is only formally diagnosed with surgery, but an experienced clinician, based on the history and a very careful pelvic examination, can have a very high suspicion of endometriosis even without surgery. So Dr. Allaire completes the examination. She tells Sheila, I think you very probably have endometriosis. And Dr. Allaire also notes pelvic floor muscle spasm. So these are the muscles around the vaginal canal that can go into spasm and become painful to palpation. And she also notices evidence of sensitization of the nervous system. So all pain ultimately is transmitted and perceived by the brain and the spinal cord. And in pain conditions, what's seen is that the nerves in the brain and spinal cord, they become more sensitive and they start to be overactive. And there's an increasing role of the importance of this phenomenon in endometriosis. And it's not that endometriosis grows on the pelvic floor muscles or it grows on the nervous system, but having endometriosis is a risk factor for developing these other conditions which can compound pain. And a sign of sensitization, for example, is issues with the bowels and bladder. So someone can notice going to the bathroom more frequently, or issues with constipation or diarrhea, or even both. So Sheila undergoes laparoscopic surgery at Dr. Allaire at Vancouver General Hospital, and she's diagnosed with deep endometriosis. This is a specific subtype where the endometriosis results in adhesions between the uterus and the ovaries and the colon. And Dr. Allaire removes all the endometriosis, the pelvic organs are returned back to their normal location, and the surgery is a success. Now, Sheila had consented to a research study. So the endometriosis tissue, after it was removed, it was sent for some genetic studies, and this resulted actually in a landmark study, and this actually did happen. We have a research program where endometriosis tissues from surgery are banked, and these tissues were sent to the ovarian cancer research team, particularly Dr. Michael Anglizio, Dr. David Huntsman, and gene mutations in deep endometriosis were discovered. And this was published last year in the New England Journal of Medicine, and Pamela Fairman had an article in the Vancouver Sun last year. It's an example of how patient participation and community participation in research can have major impact nationally and internationally and really change a field. So surgery is done and her pain is improved, but some pain she's noting is still a bit persistent, particularly the sexual pain. So she undergoes interdisciplinary care at our clinic, the BC Women's Centre for Pelvic Pain and Endometriosis. This involves a physiotherapist, counselor, or psychologist, and the goal is to address that pelvic floor muscle spasm and the nervous system overactivation. So one aspect of interdisciplinary care is pain education. So it's disseminating knowledge that the nervous system is not static, it's plastic, and pain can be changed. A pelvic floor physiotherapy addresses that pelvic floor muscle spasm, and psychological approaches, which Dr. Brotto will be talking about, things like cognitive behavioral therapy, mindfulness-based therapy, help to desensitize the nervous system. So Sheila's now 31. She's undergone surgery. She's undergone the interdisciplinary program, and her pain is definitely improved. However, the issue is she's still not pregnant. She has a friend with endometriosis who has a child after seeing a fertility center, and they're very happy with their care they've received. But let's say they mix things up and they decide to go the adoption route. So she's now 32. They've done all the adoption paperwork, and finally their son joins their family. And then that weekend, she misappeared for the first time. So that actually happened. My son Zachary came to live with us on Friday, and then my wife misappeared on the weekend, and then that Monday she texts me positive pregnancy test for the first time. So it doesn't always happen so serendipitously, but it can happen. But the point of this slide is this curve on the left. So on the x-axis is the number of months after surgery. On the y-axis is the chance of pregnancy. And the different colors represent different types of endometriosis. So for some types, the chance of pregnancy after surgery is actually not that high. But for other types, the chance of pregnancy goes up to 80% 3 years after surgery. The main point is that these curves increase slowly over time. So it's not that everybody gets pregnant right after surgery, but you can get pregnant at 6 months, 12 months, 2 years, 3 years. And in Sheila's case, it happened a full 2 years after the initial surgery. So 9 months later, she delivers a healthy girl, but a little early by cesarean section. And I only mentioned that because of this research showing that endometriosis is associated with a slightly increased risk of pregnancy complications. It's not a high risk, but it's been shown reproducibly, and a lot more research is needed into why this is the case and how this can be prevented. So let's fast forward almost 20 years. Sheila's now 50. Her daughter is a teenager, and she has painful periods. Now, endometriosis has a partial genetic component. It's not a genetic disease where if one parent has it, the child's going to have it, but there's a partial genetic component. And researchers have identified approximately 12 areas of the genome which seems to be associated with risk of endometriosis. And they're getting closer to dissecting which genes in these 12 areas are actually causative for endometriosis. Anyway, Sheila seeks early medical attention for her daughter. And we see that not infrequently at our clinic where we'll see a young woman with her mother. And her mother has endometriosis, may have had years of pain, had to undergo a hysterectomy, and her mother doesn't want the same thing for her daughter. So her daughter's symptoms are validated, they're addressed, treatments are offered, and hopefully this prevents future problems such as chronic pain. So finally, Sheila's now 65 years old. She's gone through menopause and all pain is resolved. The reason is that endometriosis is an estrogen-dependent condition. So after menopause, the ovaries are no longer producing estrogen, so almost all endometriosis will resolve after menopause. And so she's completely forgotten about the diagnosis. She's living her life, and then one day, she's noticing abdominal bloating and discomfort. And so she reads online, and she sees endometriosis associated with ovarian cancer, and she gets very concerned. So she sees her doctor, and thankfully, her ultrasound's normal. So there have been a number of studies showing that endometriosis is associated with a slightly increased risk of certain types of ovarian cancer. And the ovarian cancer research team, OVCARE, which is one of the VCHRI centers, has been instrumental in showing genetic evidence for this relationship. However, the risk is small, and so the vast majority of women with endometriosis do not develop ovarian cancer and have the same situation as Sheila, where everything is normal. But for that subset who are at risk for ovarian cancer, the OVCARE team is working hard to identify ways of prevention and perhaps early treatment. So I just want to leave you with some resources. So womenspelvicpainendo.com is our clinic website. There's a lot of handouts and videos. The second one is the Canadian Endometriosis Network. Endometriosis.org is a reviewed website. It's very accurate and very well done. And finally, I just want to publicly thank the VCHRI for supporting my salary over the last 2 years through the Mentored Clinician Scientist Award. Particularly, I want to thank the foundation and all the donors because this award made a huge difference in my career. And I want to thank the Women's Health Research Institute for supporting our endometriosis research program since its very beginning. And with all this support around us, we've been able to get national funding to continue our research program, and we hope that we'll have direct impacts and improvements for patients with endometriosis and their families. Thank you.
Thank you, Dr. Young, for your fascinating presentation. Our next speaker is Dr. Lori Brotto. She's the Executive Director of the Women's Health Research Institute at the BC Women's Hospital and Health Centre. She's a registered psychologist and holds a Canada Research Chair in Women's Sexual Health. She's also a professor in the Department of Obstetrics and Gynecology at UBC. Dr. Brotto's research focuses on sexual health in women with a particular interest in evaluating mindfulness-based interventions. Dr. Brotto, please come to the podium.
Thank you very much, Pamela. And thank you all for being here. There's few things that stand between myself and dinner with my kids. But the opportunity to speak to women about important health issues is absolutely one of those issues that I would move a mountain for. So grateful to Dr. McMaster and the team at VCHRI for pulling this event together. So no doubt we live in a sex-saturated society. Turn on Netflix and you'd be hard-pressed to find any show that doesn't contain either some direct or indirect reference to sexuality, with apps like Tinder and Grindr and Plenty of Fish, with many media messages suggesting that women can have sex when, where, how, and with whom they want. It leaves many of us with the conclusion that perhaps everyone is having fantastic and mind-blowing and satisfying and consensual sex. But if this year was any indication, with the Me Too campaign and all of the associated discourse around sexuality, what we know is that actually sexual concerns are very, very prevalent. So there have been a number of large population-based studies that have essentially asked that question. How common is low desire for you over the past year? How often do you experience pain with sexual activity? How difficult is it for you to reach an orgasm that's satisfying for you? How hard is it to lubricate in a way that is satisfying for you? And the large studies tend to converge on the numbers that are shown on the screen here. So women across ages, across reproductive stages, premenopausal, perimenopausal, postmenopausal women, the data seem to land on this number that around half of women over the course of a year will report a sexual concern that lasts at least 3 months or more. When you look at the prevalence of women having more than one concern, so perhaps a loss of interest in sex, as well as, say, having pain with sexual activity, you can see that about 1 in 4 women have that ongoing concern. The numbers are also very high in men, although slightly less prevalent in men than they are in women. And in our quick fix culture, there's been a lot of appeal around finding the single panacea, the little pink magic bullet to cure these sexual concerns in women. When Viagra was approved in 1998 in the United States for the treatment of erection difficulties in men, within the first 2 weeks there were 9 million prescriptions that were written. So there was a lot of interest around finding a woman-comparable product to treat these even more common sexual difficulties in women. Well, after a very long race that's lasted about 20 years and many billions of dollars, guess what? We finally have one. So Addyi, which is the flibanserin, which goes by the name Addyi, was approved in the United States about 3 years ago now. It was very recently approved in Canada, although it's not yet available in Canada, as the different provincial systems are trying to figure out how they're going to regulate this. So Addyi works by consuming it daily. It works on the brain to regulate some of the different neurotransmitter systems, the serotonin system, which is involved in mood, the dopamine system, which is involved in reward and expectations, and the neuroepinephrine system. Now, the research on Addyi, despite a lot of excitement that led up to its approval, again, given the blockbuster success with Viagra, it found that within the first few weeks, whereas around 9 million prescriptions were written for men, only a few hundred were written for women. So why was that? Well, these are some of the associated facts that go along with the use of Addyi. So in the United States, it's not covered under any state plan, and it costs women on average $800 a month. It's a medication that needs to be consumed daily, and the clinical trials showed that women needed to be taking this pill for at least 8 weeks every day before they started to have an improvement in their sexual desire. The women who participated in the studies were all premenopausal. They were very healthy. They were not taking any other co-occurring medication. They were not using a hormonal contraceptive. And the women were already sexually active. In fact, on average, about 3 sexual encounters per month. Now, this does not represent the women that I see in my clinical practice, who will often come in and say, Dr. Brotto, I haven't had sexual encounters for the past year, or maybe the past 5 years, or it's been 8 years since my partner and I have engaged in any kind of sexual activity. And in fact, I don't undress in front of them anymore. And I avoid going on vacation because there's an expectation that we'll engage in sex, and my friends will ask about it when I come back. So the reality is, with the medication, is that there are a number of side effects that have made the uptake of this medication very, very low. The kicker, if that weren't enough, is that it's completely contraindicated with alcohol. Some women have been known to say that alcohol as a social lubricant sometimes helps with sexual encounters, moving women into the mood sometimes. So the fact that Addie is completely contraindicated and in fact dangerous when mixed with alcohol probably explains why the uptake in the United States has been so low. So in reality, this is no surprise to those of us in the field, clinicians and researchers working, doing research on sexual health concerns in women and meeting women in our offices and hearing their stories. And the reality is that for many women who have sexual concerns, they often co-occur with other issues, often psychological issues. Perhaps the woman has had a history of depression, and might still have ongoing symptoms of low mood or lack of energy or difficulty sleeping. Maybe she's experiencing anxiety on a chronic level to the point where she's having panic attacks, which are managed by a medication. Or maybe she's a woman that has a significant amount of stress from the daily grind, the never-ending to-do lists. And in fact, there's research that shows that the impact of the daily grind, the never-ending to-do list, can be more detrimental to women's sexual function than a single traumatic event that can lead to PTSD. I'll just pause and let that sort of sink in, because that's the reality of many of our lives, is the sort of go, go, go without any time for pause. So I'd invite you to think back, if you can, perhaps to a sexual encounter or a time in your life where you would describe the encounter as memorable. So maybe it was a time when you felt very in sync with a partner. Maybe it was a time where you felt that your desires were validated. Maybe it was a time where you experienced a mind-blowing orgasm from head to toe on your own. The specifics of the situation really don't matter, but there's one common thread across these encounters, and that is women describe that in each of these memorable events, they were fully there. They were fully present. They weren't noticing the beeping phones. They weren't thinking about bringing their kid to their soccer game. They certainly weren't thinking about what to make for dinner or the talk they had to give the next day. They were fully in the here and now. And so I've been largely preoccupied with this, what I've come to learn in my research and in using mindfulness with women. This is probably the single most powerful panacea that we have on hand for addressing sexual concerns in women. And so what do we mean by mindfulness? I probably don't need to define it to this audience. Mindfulness has gained a fair bit of recognition over the last 10 or so years, although it's really been over the last 40 years that mindfulness has made its way into Western medicine and Western healthcare. And essentially we define it as non-judgmental awareness, where every thought, feeling, or sensation that arises within your attention is acknowledged and accepted as it is. So it's a way of paying attention, but it's more than just paying attention. It's how we pay attention. It's paying attention on purpose, and it's paying attention in a non-judgmental way. So I'll give you an example. If you're following along with what I'm saying right now, but there's a very good chance that most of you over the last 5 minutes have had another thought. What on earth is she saying? Where is this going? What's happening tonight? How is this relevant? Oh my gosh, this is relevant. It's that ability to notice when the mind takes off and gently tug it back and bring it back into the present moment. So it's far more than just cultivating attention. It's about doing so in a way where you're very compassionate to yourself. So what do we know about mindfulness? Well, starting in about 2003, when I was a postdoctoral fellow at the University of Washington, and doing research with cancer survivors, many of whom, after their radical hysterectomies, described a complete disconnection with their bodies. They described no longer feeling any degree of pleasure while they were engaging in sexual activity. In fact, many of the women described it as though when my partner touches these parts of my body that were previously positive, it feels like they're just touching my elbow. I feel that there's touch, but there's no association to pleasure whatsoever. So this was the first group of women that they allowed me to teach them how to bring mindfulness into their lives and into their sexual encounters. And what those women taught me was that they could feel again, that those feelings could reconnect them to their sense of self and their sense of well-being. And women who were previously convinced that there was no sensation whatsoever were suddenly feeling sensations in a way that was even stronger than it was before their radical hysterectomy. So with those findings, and then beginning my appointment at UBC, we then broadened our sample to include women who were seeking treatment for the most common sexual concern, which is lack of desire, no longer being interested in sex. And so for these women who believed that the flame of their wanting was gone, that the only way to rekindle desire again was to relive those instances of their first relationship. And what those women learned with mindfulness was that they could cultivate desire again, that by paying attention, by noticing sensations, by noticing the triggers of their desire, that their desire could actually be stronger than it was before when they relied on an automatic sexual response. We also learned that my graphic didn't show up, but we also learned that for women who have a history of sexual abuse, who now found themselves in a consensual, in a happy sexual relationship and who wanted to engage in sexual activity, yet in spite of that consent, they were being re-traumatized, having memories of their traumatic past resurface during sexual activity, and who were having flashbacks and nightmares. Mindfulness was a way of keeping those women in the here and now and preventing them from going back into their horrific past. And finally, the group that we've worked with most recently are the approximately 20% of women who experience chronic burning, cutting, searing pain with any kind of contact to the vulva or vagina. Women who can't wear tight jeans because the seam produces such pain. Women who have difficulty riding a bike because of the excruciating pain. And mindfulness was a tool for them to use to ride out the distress, and in so doing, over time, their actual pain intensity decreased. And that was not a finding that we were expecting. What we were expecting was that we were giving women a tool to cope with the anxiety and the sadness and the loss around their pain, but it did so much more than that. So how exactly does it work? And this is the most common question that women ask me. How on earth does paying attention to my breath, paying attention to the feelings in my body, how does that translate into improving desire, into reducing pain, into putting me into touch with my body again? The answer is we really don't know, but this has been the focus of our research more recently. There's been some evidence that mindfulness does improve mood. In fact, there's been a lot of evidence that mindfulness can not only improve mood, it can prevent a relapse in depression in people who have a history of even repeated depressive episodes. And because low desire often co-occurs with depression, this is probably one of the mechanisms that it serves to increase desire. We also know that women who have sexual concerns are especially judgmental of themselves, of their bodies, of their feelings, of their selves. And mindfulness is one way of teaching them to be kinder. And we found in our research that in decreasing those negative self-talk, that's probably one of the ways that it serves to improve sexual function. How many of you can relate to this? Mindfulness reduces distractibility, and the reality is that distractibility and pulled into a multitude of direction doesn't stop during sexual activity. But mindfulness is probably a very effective tool of redirecting the mind so that women can remain right there. We also have evidence that mindfulness reduces stress, not only self-reports of stress, I feel so stressed, but what the body is doing during stress. So mindfulness actually regulates our natural and normal and healthy cortisol rhythm, which is supposed to start high in the morning and then decrease over the course of the day. But when we're in a state of chronic stress, our regulation goes awry and we don't have that nice drop in cortisol. So what we've found through our research is that mindfulness helps regulate the stress response, and that probably helps with sexual function as well. And finally, and this is probably not surprising, mindfulness allows us to be more in tune with what's happening in our body. There are some people who are very in tune with subtle changes in heart rate, in blood pressure. There are some women who actually feel when they ovulate. And then there's a whole lot of us who have no clue what's going on inside our body. So mindfulness training actually allows us to tune into those sensations within our body in a way that probably translates to improving sexual function. So my hope over the course of this talk is that you've learned something new about mindfulness. I begrudgingly wrote a book on the topic because I learned that the only way to get scientific findings out to the public was not to just write them in medical journals, but to actually talk to the public. And my hope for you is that this practice of paying attention non-judgmentally in the present moment, moment by moment, is the key to not only mind-knowing sex, but mind-blowing sex. Thank you.
Thank you very much. Our final speaker for the evening is Lana Berry. She is a coordinator for the Chronic Conditions Self-Management Program at the University of Victoria, which promotes health and wellness locally. After developing a chronic condition called provoked vestibulodynia, she became a women's sexual health and advocate and has recently been a co-lead investigator of a study related to this topic. Lana will be sharing her personal journey in a bid to shed more awareness and to let us know that it's a real condition, not just something in the heads of those who suffer with it. Please join me in welcoming Lana.
Hi, everyone. Thank you for being here. I have to say that all of a sudden, just listening to Lori, I'm very emotional. But that's good. That's good. I'll get it out of the way right away. Let's see here. Okay, great. I wouldn't be here today if it weren't for everybody right here, because when you do have an invisible chronic condition, as I have spoken to so many more in the work that I do, you do start to believe you are invisible. And so I just want to say that after a very long journey to get here, I'm no longer invisible, and I'm very happy to say that for all you women out there who are listening on the webcast and who are here in the audience, there is a lot of help out there for you, and please just never give up. I'd like to start there. Thank you. Okay, so this is me in a nutshell. I'm going to talk to you today about my story, about my personal transformation to be able to stand here in front of you today, my new identity, because I am no longer the person that I was before the accident. I am brand new. and for the better, by the way. And now my path, yes, I am Laurie's warrior now. I am a warrior for women's sexual health. And yes, ladies, it is true. You really can have mind-blowing sex with provoked vestibular dynia. It is possible. Yes, it is possible. Please use your inserts, ladies. They work. Okay, starting out. So I was on my way for a wonderful opportunity on the 1st of November 2012 when I got hit by a car. I was the passenger in that vehicle. I had the soft tissue, all those things, the upper and the lower back pain, fractured left elbow, and, you know, cuts and bruises, that type of thing. So I had a headache, I had those type of things, and I didn't think too much of it. It was just day after day, week after week, that I started to have pain in my pants, and I didn't know where it was coming from. So in the middle of the night, I would get up, I would go out with a mirror, and I would realize that there's nothing there, that this must be all in my head. So I felt very ashamed. I started to think, what was it that I must have done to cause this to myself? And it was only after roughly 4 months of suffering in silence that I went to my GP, and he asked me, what's wrong down there? And I thought, I said, well, actually, I'm having pain in the entrance of my vagina. So he got all the tests done. They all came back normal. So he did not know what to do. So he sent me to see, he said, well, I'm going to go send you to see a gynecologist, which he did do. And that gynecologist, as Dr. Young will relate to, told me to go home and relax and to drink a glass of wine. So I decided to drink the whole bottle just to see if it would help, and it didn't. So naturally, it goes without saying, I had a lot of anxiety just to even get in there, a lot of panic attacks, which before this I had never, or at least to my knowledge, I would have had these things, but they would have only happened just brief periods of time. This anxiety was with me at all times, and so were the panic attacks. And then the depression started to kick in without me even knowing what it was, that I just had this sense of hopelessness and that there was just no way for me to get out of the darkness. But finally, I did get out of the darkness. But I do want to just jump in there and go back to go under my solution with my GP, who said he had given me medications for the pain in other parts of my body, and he thought this might help me as well to calm down a little bit. And after I went back to the physician again, after those medications did not work, he sent me to see a psychiatrist, because at that point I was told that it was all in my head. Happily, the gynecologist was able to work with me to tell me, quote unquote, you are not depressed because you want to kill yourself, you are depressed because you have a broken vagina. And I said, now we're finally getting somewhere. So I took her medication pads, whatever it was she gave me. I went home, I tried to take some of them, and as I may refer later on, it numbed my mind, but it absolutely did not numb my pain. So because I had this real desire, I love my sex life and I wanted it back, I kept on going back, and finally he sent me to see another gynecologist who I was so grateful for, had done an elective course at BC Women's Hospital, and I had done my research with the psychiatrist to know that it had to be some type of nerve damage that we were talking about, and in the end, I got the word Q-tip test. And off I went to my gynecologist with this word, and she knew what I was talking about it, and within 3 seconds I cried my eyes out for the first time in this journey with joy. She said, oh my goodness, you have provoked vestibular dynia. And that's when my real journey began with Dr. Brotto. I got the referral, and then from this lovely lime green piece of paper that the advertisement was on, I kept it. I will frame it. This is my life. This is my lifeline here. Okay, my personal transformation. So I wanted better sex. And that's what motivated me to break my silence and share my experience so that others also may get the help that I have gotten. I wanted to take take responsibility for their sexual health as well. So for those of you that are out there now that are listening, please, please, I will say this again and again, please reach out for help. It is out there. For me, being a research participant absolutely changed my life, because Dr. Brotto and her team showed me the science behind what was happening. Because I remember her one time, she goes, now, I'm about to, tell you, I'm not going to give you any pills, I'm going to tell you, to go home and be mindful. And what do you think about that? And I thought, well, you know what? I don't know what I think about that, but I'm going to give it a try because everything else up to this point hasn't worked. And by the way, it works. It works, it works, it works. I can't say enough. What else being a research participant did for me is it, of course, provided support and confidence building with myself, with others, with the team, created a safe environment for us to be able to say what we needed to say and when we needed to say it. And I was able to walk away by being more positive about my future and my sex life. And also, as you can tell by the work that I do now, I'm able to give back to others with their chronic conditions because, yes, depression, anxiety, panic attacks, all these things are really real for all of us who have chronic conditions. And now I'm a good self-manager. I, of course, work with Self-Management BC, which is funded by the Ministry of Health with the University of Victoria, and I took the self-management workshops, and I now work as the online coordinator. I do daily mindful and practical techniques from the Comfort Study. My new identity. First of all, change my belief systems, and thanks again, as Dr. Brotto has mentioned already, awareness, my mind-body connection, and to accept my new self and to change myself accordingly. Just as a very quick example, when I wake up in the morning, the first thing I do is I write in a gratitude journal 3 things that I'm grateful for every day, because sometimes I have anger issues and I want to make sure that I start my day out on a positive note. I also, of course, meditate 3 times a day. I learn specific skills and practical cognitive skills through self-management, and some of those include problem solving, decision making, and action planning. And right now, obviously, I'm a self-advocate, and I want to communicate and share my experience, and as well, I was a co-investigator in the PVD campaign and the narrator of the PVD video. And almost lastly, my new path, a warrior for women's sexual health. Right now, actively speaking out and communicating my sexual health story, advocating for women's sexual health research, of course, helping women live better lives with sexual health issues, becoming more empowered through the stories that I tell and through the stories that I have heard. And I know that there's some women out there listening that I have been able to speak to personally, and I want you to know that you are not alone. And raising awareness through social media. I have had the pleasure of being the narrator of a video under the campaign with Dr. Brotto. And I want to ask you, please act now. So under the PVD campaign, where you can find me personally, and under Self-Management BC. Thank you so much for listening.
Do we have a question from the floor? Yes, we do. Back there.
I can just shout if that's okay.
You shouldn't have to.
Sometimes we do have to shout.
There we go. So this is a question for Dr. Brotto. Doing mindfulness to treat patients who have been told this is not in your head, but then you're sort of dealing with it in a way that's saying we're going to do something in your head. How would you sort of speak to patients who are first coming up to you and saying, like, what do you mean mindfulness? Because it's so much more than just in my head.
Great question. I'm so glad you asked that because it's a bit of a paradox, isn't it? Right? We're saying it's not in your head, which means you're not making this up. This is real. What you're experiencing is a real condition. There are millions of other women who do. And yet, on the other hand, we're saying here's this strategy which essentially involves a head-related technique, and it might be useful. And so I never just stop there. I always fold in the science. And I think it's really important to understand just how and where mindfulness works. It's not some airy-fairy tool that we really don't understand. There's actually a lot that we understand thanks to neuroimaging studies, thanks to high-quality scientific studies of how and where mindfulness works. And we can actually trace the locations in the brain where mindfulness not only changes the function of those brain areas, but it can actually lead to neuroplasticity, which is growth and sprouting of new neurons. So in the case of, let's say, pain, for example, one of the things we know is that in a chronic pain condition, not an acute pain condition, stubbing your toe, but in a chronic pain condition, is that over time there can be actually changes within the brain such that when the person experiences pain, they experience anxiety at the same time, depression at the same time. You have activation of the amygdala, which is the emotion center of the brain. You have activation of the motivation center, the thinking center. And so often what happens in a chronic pain, and in particular PVD or sexual pain, is that the pain itself is not experienced in isolation. You have this kind of flurry, this whole brain activation that happens. And so what mindfulness does is it actually quiets down those parts of the brain that are really not needed when one is coping with pain, right? So anxiety doesn't actually help us when we're coping with pain. Being sad and depressed does not help us when we're coping with pain. And what the research on mindfulness shows is that you actually have this uncoupling of the different parts of the brain such that you have activation of the pain centers, but you no longer have activation of the emotion center, the thinking center, the motivation center, the somatosensory cortex. And so I think it's really important to understand the brain mechanisms. And in fact, what's important for us, all of us to know, and I say this quite emphatically as a psychologist, is brain and body are connected. It's not that the brain does one thing and it exists in one universe and the body does another thing. We've got lots of evidence of chronic health conditions that take a toll on the brain and on the mind and on our mood and vice versa. So I think really understanding the underlying science and mechanisms for how and why that works helps us grapple with that apparent paradox of, okay, it's not in your head, but it is in your brain.
Hi, this is also a question for Dr. Brotto. I'm curious if the methodologies for mindfulness training for sexual health are any different from the methodologies for mindfulness training more generally, for, say, anxiety or depression or say, mental illnesses.
Great question. Maybe let me ask the audience, how many of you are familiar or who have heard of mindfulness before? Awesome. Keep your hands up. Keep your hand up if you practice meditation in any sort of way, meditation or mindfulness or some form of it. Okay, so quite a few people. That's sort of representative of what we know today. So the question is, are we just kind of sitting on a pillow and learning how to pay attention to breathing and our body, or is there something specific to sex specifically? And what we've found over time is that learning a regular daily mindfulness practice, yes, the kind of classic meditation practices that you might do for coping with a low mood or with stress or with anxiety, can be really, really important. And then in addition to that, we layer on top of that specific mindfulness exercises for the person to incorporate when they're being sexual, either alone and or with a partner.
Hi, I was just curious. It seems like a lot of these issues that women are facing in silence, they often start with an encounter with a GP that is often not the most positive, in which their pain is, not validated. And I was just wondering if there is anything that's kind of being done to address that on that level of primary healthcare to address women's pain, or if there's anything shifting in that domain so that women don't walk into their first line of defense and get turned away.
Yeah, I think so. I think things are definitely changing, and these topics are being covered during medical school and during residency. So hopefully these stories we don't hear them in the future anymore. So I think the primary care attention to these areas is on the upswing for sure.
And may I just add to that, like in relation to my GP, when I first saw him, the old saying, when you know better, you do better, because afterwards, when I went back to my GP, he shook my hand and he said, because of my situation, he has now 4 new patients with the same thing, and it's only through going through this process that he realized. Thank you.
Laurie, can I just ask if you think that going to a female doctor was very important to getting a proper diagnosis?
In my case, yes, because my GP was a male and the first gynecologist was a male, and when I went to my second gynecologist, she was female, and she did know about the Q-tip test, so the answer is yes.
I think maybe you should elaborate on what the Q-tip test is.
Fantastic. It's really exciting, everybody. A Q-tip test is actually if you believe you have provoked vestibulodynia, which is pain specifically in the vestibule, which is the entrance of the vagina. The Q-tip test will accurately, to my knowledge, and you can certainly correct me, is that you take the Q-tip and you put it in a certain place, and if the nerves does a certain thing, ding, ding, you have PVD, correct?
Sounds good.
Yep. Okay, great. Thank you.
Other questions? Yes.
Hi, I have a question for Dr. Paul Young and about endometriosis and the diagnosis of it. And you said that it doesn't have to be painful. Have you had any patients come to you coming from, let's say, like a Chinese medicine doctor, or like something that happened to them? They went to a acupuncturist and their periods started changing due to certain changes in their body after getting treatment and coming to you, and you working with them and discovering that they have underlying endometriosis and they didn't know for a long time?
So sometimes it's pain. Another common reason for referral is fertility issues, where sometimes they can have fertility issues and pain, or fertility issues and no pain whatsoever. The other reason for referral we get is sometimes an endometriosis cyst of the ovary, which can have pain or no pain, or can have fertility problems or totally normal fertility. So it's quite variable. And I think it's also quite variable on the stories of the people who come to the clinic. So they can come from their family doctor, from a specialist, from a complementary care provider. Sometimes it's really driven by the patient who's told their doctor, I think I have endometriosis, I want to be seen. So the story is really variable. And with respect to traditional Chinese medicine, there's one randomized controlled trial recently came out that seemed to show benefit for endometriosis-associated pelvic pain. And so, that there's actually some possible promise in that area for helping pelvic pain.
Thanks. My question is for Dr. Lee. I know you're talking about the vaccinations being relatively effective for kind of all age groups, or maybe that was what I was taking from your statement. I'm curious if there's any push to have that coverage at like a provincial level be expanded? Because you had said also that it's only covered for people who were born in 94 and earlier, which is really great to get that demographic. And I'm wondering if that would obviously increase the uptake by having that be provincially funded. Thanks.
Good question. So HPV vaccination is obviously most effective when you give it to kids, and there's a couple of reasons for that. One is that they usually haven't been exposed to it yet, but the other is actually that their immune system response to vaccination is actually a lot stronger before they hit puberty than it is for adults. So when you were talking about a public health funding for a vaccination, it's definitely makes sense to cover giving HPV vaccination to kids. When you talk about expanding that to other age groups, because some people have been exposed already, then you still have potential impact, but your impact is going to be less. And so from whenever they make these decisions about what to cover, it's always dollars and cents is an important thing. So, I mean, I think on an individual basis, I support vaccination for a lot broader indication than makes sense from a government-funded, universal public health plan type perspective. Hopefully that answers your question.
And are you recommending that all women over the age of 45 get vaccinated?
That's not a black and white question, of course. So, I mean, like I said, HPV vaccine is the seatbelt analogy, because if I could predict the future, my job would be a lot easier, and you would be able to know who would benefit and who wouldn't benefit. And when we're talking about vaccine effectiveness, we're looking at a group of people. So we say it has, X chance of preventing disease in this group of people, and this group of people, and this group of people. But as individuals, you're either on one side of that equation or the other, and we don't actually know who's going to be on which side. So we have to think about, what the potential benefit is to you and what the potential cost is to you. So, and cost comes in dollars if you don't have extended health coverage, and cost comes in side effects, which for the HPV vaccine is thankfully low. So the risks in terms of that are really low. So you get a needle in the arm, that doesn't feel very nice. Some people get a red mark, some people get a headache, some people faint when they get needles, but other than that, there's no serious adverse effects. So the risks of the vaccine are low, and there is potential benefit, but on an individual basis, it's a little hard to put numbers on it. And for women over 45, we don't actually have data on that. So the original vaccine studies were done in girls and women from 9 to 45, which is why it was originally approved and marketed to that population. So we don't have numbers to tell people in that situation. So it's a bit difficult to black and white say you need the vaccine, you don't need the vaccine, because we can't predict the future. But I think the potential is there for most people to benefit from it. And beyond that, it's a bit hard to put numbers to it. Yeah. And I think there are, definitely certain high-risk populations, such as people who've already had disease, actually have more significant risk of having future disease than someone who hasn't. So, I mean, that might be something that we could, advocate for coverage for people who've had treatment for HPV-related diseases or something like that. But it becomes a bit challenging to put numbers to things beyond. We don't have evidence for it, but I think it makes sense for a lot of people.
This question's for Dr. Young. You spoke about hormonal therapies and surgical therapies. I'm wondering if there's a role for immune suppressant therapies for endometriosis.
Not currently. There's been a few studies that so far haven't shown a benefit, but as part of our research program, we are investigating protein called interleukin-1 beta, and it seems to be correlated with pain and seems to induce nerve growth around endometriosis, and some endometriosis seems to overexpress this protein. And so the dream, if hopefully one day, if before my career is over, we'll be able to find some sort of non-hormonal alternative, drug alternative, perhaps targeting the immune system. And the good news is there's actually drugs available that target proteins such as that are used in other diseases. So hopefully things can move faster one day. But definitely that would be the something we'd really like to see, especially for those that have side effects on their hormonal therapy, and then those who are trying to get pregnant. Because I have some patients that do so well in hormonal therapy, and then they decide they want to get pregnant, and the moment they stop the hormonal therapy, each period is so excruciating, and I see them like once a month or once every 2 to 3 months just to help them through that process. And sometimes they have to go to a fertility center really quickly to try to facilitate getting pregnant faster because the natural cycles are so painful. So definitely, hopefully one day.
We have only about 4 minutes left.
Well, I actually had two-part question for Dr. Lee, but I'm one of those parents who did not. I have two daughters, and it was the first year that they were doing the vaccinations, so I did not sign the form. You said, so you get it through you ask your GP to give you the vaccination, and there's a cost now to them?
So if they were born in 94 or later, then they would be covered under the catch-up program and could get it through the community health centers for free.
1989 and 1991. So.
Right. So there would be a cost, unfortunately. If they're covered, if you have any extended health coverage, HPV vaccination is often on the list, not always though. The cost, if you're curious about the cost, so it's 3 vaccine doses over a 6-month period, and that's for people 15 and over. They're actually giving 2 doses to the school-age children because of the increased immune response in that age group. So the cost of the bivalent, so the one that covers the 16 and 18 types, is about $100 a shot.
Okay.
So over 6 months, and the cost of the 9-valent is about almost $200 per shot. So it's about $600 over 6 months. So it's not cheap. It is spread over 6 months, thankfully, but it is a significant cost.
Okay, thank you. That was helpful. I have another question.
Yeah.
I just went to my doctor to get tested for diseases, the sexually transmitted diseases, and I asked her to test me for HPV. Well, now I'm learning HPV is many different diseases. She actually said, no, there's no test for HPV. So in actual fact, when you say 80% of people or women have had or HPV in their lives, that is people that you've actually diagnosed some type of disease from.
No, good question. So that figure is based on research studies and on other screening studies where they've used HPV testing. In BC, we currently don't use HPV testing for cervix screening. It is being looked at. It has been piloted in some other places in the world as a screening test. I don't actually recommend HPV testing as well because we don't have a treatment for it. So outside of the context of a screening program, or in BC we use it post-treatment for cervical precancer. As a test of cure, we use it to put women who are low risk back into pap smears and women who might have a higher risk of recurrence coming back to colposcopy, which is where we see women with abnormal paps and we do treatments for precancers of the cervix. But using the test outside of that can be a bit confusing as to what to do with the result and anxiety provoking. And a lot of people are curious about whether they have it or not, but the reality is we can't actually treat it. We have treatments for the precancers and cancers caused by HPV, but we don't actually have a treatment for the actual infection. And actually most of the time the infection goes away on its own and doesn't matter, in terms of your health overall. So sometimes not knowing is better if it's going to go away, but it's a hard thing to wrap your head around for sure, and it's a hard thing to talk about with with people.
You want to know you've done everything you can do, so
Exactly.
I think I have.
Yeah.
Thank you.
Yeah.
Ask a question about the vaccine. So for those youth or people who have had the old vaccine, would you recommend the Gardasil 9 now? And what does that look like? They have to start from the beginning, or?
Right. So the question is whether people who've had the old vaccine, so whether they've had the bivalent or the 4-valent, whether they should get the 9-valent, which covers 9 types, the 7 cancer-causing types. So I support that for people, but I don't necessarily recommend it. So it's again the question of how much are you going to benefit? I don't know. If you have the funds to do it, by all means, I think it's reasonable to do, and I would write a prescription and I would support that, but I wouldn't push it on anyone, because I think that, you know, covering 70% of cervix cancer causing types, and the HPV 16 is also the main culprit for the other body sites. I think you've got a pretty good coverage there. If you are going to do that, it's a separate number, so usually an extended health plan will actually cover the new one as well as have covered an old one. So you can still get coverage if you want to get the 9-valent. Again, the benefit is a crystal ball question for anyone. But the other question was whether you need to start over. And yes, you do. To have full coverage for those extra 5 types, you need to start your series over and take the full 3 doses. Because if for example, if you only had 2 of the other one, if you have a 3rd dose of the 9-valent, all you're doing is adding your 3rd dose for those 4 types, and you've only given 1 dose for the additional 5 types, so you won't get full benefit from that those additional 5 types with only 1 dose. Does that make sense?
Okay, I think we have to wrap things up now. Thank you for all your questions. You asked very relevant questions, and it shows that you were all paying attention for the past hour and a half. Very briefly, before we go, I'd like to say a quick thank you to all the community partners that helped make this annual event such a success. I'm going to list them now. The Women's Health Research Institute, the University of British Columbia, Y Yoga, the Vancouver Women's Health Collective, Self-Management BC, the BC Support Unit, Whole Foods, Ove Care, and 4 more. True Nosh, Dense Breast Canada, Libra Nutrition, Good Night Out Vancouver, and to the Vancouver Coastal Health Research Institute, I want to thank you for sharing your expertise here tonight. And have a safe trip, everybody, going home tonight. Thank you.